relevant in the prevention of ASCVD. And I also hope to share with you my insight in how to choose the right proper treatment. And as mentioned by the chairman before, we have a large number of new drugs becoming available in the market today and even tomorrow. And these drugs are exciting, but they also have what we call some negative aspects, especially regarding the cost. So these are my disclosures, and these are the topics I will share with you. Short introduction, why cardiovascular disease remains a really important point in healthcare. Then we'll talk about the why, who, how, and when to treat patients with dyslipidemia, particularly with high LDL cholesterol, and I will conclude my presentation with some remarks. So, let's first recognize the fact that managing patients at risk for cardiovascular disease is a different kind of medicine than treating patients who've had cardiovascular problems. Prevention, I think, is the next challenge in modern medicine. In the old style medicine, doctors were always focused in the disease, the problems that patient experienced, and tried to find solutions to mitigate those problems. When we talk about prevention, we're going to do activities, we're going to prescribe medicine, not to treat a symptom or a problem, but to prevent symptoms and problems. And that is far better outreach in terms of what we can accomplish. I will show you. But it makes it also a little bit more difficult because patients are not accustomed to doing things to prevent a disease they don't feel. And especially when talking about cholesterol, it is something they don't feel and sometimes also not aware how relevant that is. This slide shows you, and I think for me when I saw this article in 2017, that the first sign of atherosclerotic complications is a fatal one. That means secondary prevention is a little difficult. If you have a fatal event, there's not much we as doctors can do to alleviate that. And that's in 40% of the cases. That means we have to act sooner. We have to act earlier to make sure that you don't get a fatal event, or perhaps even possible not to get an event at all. How prevalent is atherosclerosis? Well, this is another perspective. Data from the United States, from the NHANES registry, shows that the first cardiovascular events happens in 25% in males below the age of 55. This is an important piece of information because 55 and younger is what we call premature cardiovascular disease. Half of the first events are before the age of 65. And in women, they're slightly protected before menopause, so it's 15% and 33%. But in the long run, more women die from cardiovascular disease in total numbers compared to men. And if there's one group that is not properly diagnosed and treated, it's actually women. So there is a bigger challenge in this population as well. Now, when we want to address this non-communicable disease, we have to know a little bit more when it starts and what are the most important risk factors that progress atherosclerosis and cardiovascular complications. So why? And before I start in the actual treatment part, I want to ask you a very simple question. There is what we call normal and there is what we call abnormal, right? If something is normal in medicine, we don't do anything. The reason is, it's normal. And when we talk, for instance, about blood pressure, I think everybody agrees that the threshold of a blood pressure that pushes us to do something is roughly 120 or maybe 130 millimeters mercury. If it's below that, we can relax. It's normal. If it's above that, we know it's associated with an increased risk for strokes and coronary artery disease. So we act. Glucose, similar. We know the threshold is roughly 190 milligram per deciliter. If it's above that, we diagnose patients as diabetic. And we know that diabetes patients have a risk of microvascular and macrovascular complications. So we get active to address that issue. If it's below 90, we say it's normal, and we relax and we say to the patient, don't worry. Now cholesterol. What is a normal cholesterol in Vietnam? What is the value? Who is brave enough to tell me? What do you consider a normal cholesterol level, total cholesterol in your patients? I see a lot of silent faces. Who is brave enough to give me a number? Okay, I'm going to ask somebody. You, what is normal cholesterol in Vietnam? $120 for LDL or for total cholesterol? LDL or total? LDL. Okay, so if LDL is 120, then total cholesterol is about 200, approximately? 5 millimoles? I think so. 200 or 5 millimoles is actually what we consider normal, not only in Vietnam, but in every country I've been. In Europe, US, South America, Africa, Asia, you always hear the number 200 or 5 millimoles. So, if normal is something that is not associated with disease, is this the case with cholesterol as well? Is a number of 200 healthy? No need for action? Actually, no. Because we know atherosclerosis is prevalent in almost everybody here available. We not always die from cardiovascular disease, but I can promise you, we all gonna die with cardiovascular disease. Because atherosclerosis is omnipresent. And the reason is that a cholesterol of 200 is an abnormal level of cholesterol. Yes, everybody has it, but it's not normal. And the reason it is so high is very simple. We were not designed to be exposed to high calorie, high fat, high sugar, high salt diet, and without a lot of physical activity. We were designed over hundreds of thousands of years to eat small amounts of foods and spend a lot of energy getting that food. In the last 150, 200 years, that has changed. And our physiology doesn't change as quickly, so we pay the price of modern civilization. Now, to illustrate my point, I like to share with you this slide. These are 3 graphs. These are human, pigs, and sheep. We call them mammals, and I could show you another 50 mammals with actually the same outcome. This is plasma total cholesterol, and here you see 3 phases: fetal, breastfeeding, and adulthood. And if you look at the graph, you can see that during the fetal period, total cholesterol is about 50 to 70 in all mammals. Then after birth, there's a change in diet, and the small born babies are getting breast fat. And mother's milk is high in fat, high in protein, high in calorie, high in sugar, high in everything. And that's necessary because you go from something very small and tiny to something big and large. And especially in the first phase, there's a lot of development that needs to be sustained by sufficient calories. And what happens is that cholesterol rises dramatically, see? In all mammals. But in pigs and sheep, when mama sheep and mama pig stop with breastfeeding and kicks out the offspring, they say, find your own food. And the small sheep and pigs start to eat what mama pig and mama sheep eats as well. But in humans, after breastfeeding, cow's milk. After cow's milk, before you know it, Happy Meals. After Happy Meals, Western diet. And you can observe that cholesterol levels in humans stays actually very high. While in the other mammals, it goes back to the level of pre-birth. Total cholesterol of 50 to 70. And we have data from some primitive populations in South America and even in Asia, where they still follow the lifestyle that our ancestors did for many hundred thousands of years, and their cholesterol is very similar to this. And atherosclerosis is absent. So I'd like to pose that a normal cholesterol, like a normal blood pressure or a normal glucose, is actually 50 to 70 milligrams per deciliter. That is the level where it's not possible to develop atherosclerosis. Now that doesn't mean that when you go to your practices tomorrow, that every patient comes in, you say, oh my God, we need to get you to normal, we're going to give you all kinds of drugs to lower your cholesterol. No. But the point is, first of all, realize that normal is not 200, so that if a patient has cardiovascular disease and you're wondering, yeah, but his cholesterol is normal, should we do something? No, his cholesterol is not normal, it's abnormal. And the second thing, if patients get to a very low cholesterol, don't be scared that that is harmful. Because what you're just doing is getting to a level that is normal again. Now the consequences of having exposure to abnormal levels is depicted in this slide. This is a young boy, 3 years old, who died. I'm not sure if it was a car accident or a shooting. This was in the United States. And what you can see is the first signs of atherosclerosis, a fatty streak. Did this boy smoke? I don't think so. Did he have hypertension? 3 years? No. Diabetes? Unlikely. So what risk factor is left that we could address? It's cholesterol. Cholesterol is the driving force. This is one boy, but this is looking at many boys and girls. This is the Bogalusa heart study that did post-mortem examinations in children that died from different causes. And they found that 50% of the children already in the age from 2 to 15 had already atherosclerosis. And even 1 in 12 had signs of a real coronary atheroma. Look at these pictures. 29-year-old female homicide victim, 23-year-old male homicide victim, 19-year-old male suicide victim. All of them at this young age have coronary arteries that are already affected. And what we can learn from this is that the disease doesn't start when we're 50 or 60, but the foundation is laid in our early teens, and the manifestations already happen in our 20s and 30s. So, now we know that atherosclerosis is something that is related to an abnormal cholesterol, and that abnormal cholesterol is present in practically everybody on this planet. It used to be a prevalent disease in Western economies, but we see now a huge uptick in developing economies because of changing lifestyle. So in Vietnam, I'm sure that is the same. Who should we treat? Well, we have what we call now evidence-based medicine. That means the treatments that we use in our patients have to be established in randomized controlled clinical trials, placebo-controlled clinical trials with endpoints. And these are the statin trials that were proven, that had proven that using a statin to reduce events really works. Primary prevention, secondary prevention, this is mean LDL on trial, and this is your event rate. The trials that conducted these studies are shown here on this slide. You can see on the top level the different statins, pravastatin, simvastatin, atorvastatin, and rosuvastatin. And here you see the different populations. This is primary prevention, this is secondary prevention, and this is stroke, renal failure, imaging trials, and all the different subpopulations. I'm going to blank out pravastatin and simvastatin because we predominantly use atorvastatin and rosuvastatin. And one thing that really becomes clear is that if we look at the evidence for high-dose statin, atorvastatin produced the burden of that evidence. In primary prevention, those were all trials where we weren't sure yet that statins were safe. 10 milligram was used, but in all secondary prevention trials, in all imaging trials, in stroke and dialysis trials, you can see 80 milligrams was used. For rosuvastatin, we have 20 milligrams in primary prevention, and then these trials actually didn't show the expected benefit. And only 2 imaging trials used 40 milligram, and these were actually quite small trials. The trials that didn't show evidence didn't show harm, but I think the burden of evidence is clearly in the atorvastatin high-dose group. The UK NICE guidelines, they not say high-intensity statin, they say atorvastatin 80 milligram is actually the preferred statin. Based on these trials, guidelines were formulated. And these are the European guidelines, quite simple, looking at different risk categories, and based on your risk, targets for treatment. So it goes from 116 to 100 to 70 and to 55, and as an alternative, more than 50% LDL reduction from baseline. These are all secondary prevention, these are all primary prevention, and these include also primary prevention, but high-risk primary prevention. So we now know what to do and why to do, how to do it. And I think it's good to look back to the history of statin trial. And one of the first trials, or actually the first trial, that showed lowering cholesterol was really effective was what we call the 4S study, the Scandinavian Simvastatin Survival Study. And it shows you that in the placebo group, the LDL was 190 versus 122 in the patients that got simvastatin, and the mean dose was 20 milligrams, and that the event rate went down from 28 to 19.4%. So a 30% LDL reduction translated in almost a 30% event reduction. We jump 10 years and we go to the TNT trial, treatment to new targets. Not a placebo-controlled trial, but comparing 80 milligrams with 10 milligrams, because we already know statins were effective. Now we wanted to know, is it more effective to be more aggressive in treatment? And yes, it shows. Achieved LDL in 10 was 100 versus 77 in the ones that were treated with 80 milligram. Event rate was 8.3, and the event rate here was 6.7. So if you want to reduce risk really dramatically, you have to do what they did in TNT. And in TNT, patients got treated with 80 milligrams of atorvastatin and not with 20 or 40 milligrams of simvastatin. Now, we have to be also a little bit critical. I think the evidence of trials is quite clear, and as you know, we now have new drugs that allow us to lower cholesterol to unprecedented level. We've seen patients in trial with LDL of 15, of 5. And of course, there's now a lot of impetus to say, yes, we have to go to the lowest as possible, because cholesterol has a linear relationship between the level of cholesterol and your risk of cardiovascular disease. And that is true. There is no J-shaped effect. There is no uptick if you get to very low levels. But there is one important feature that I like to illustrate. And the feature is that if you get to lower and lower levels, the curve starts to bend off a little bit. It's not as sharp as in the beginning, but it changes its shape. And the best way to show you, to illustrate, is using this graph. Based on the TNT analysis, we know 40 milligrams of LDL reduction gives you approximately a 20% reduction of cardiovascular events, right? Now, this is based on the IMPROVE-IT study. IMPROVE-IT was ACS patients using simvastatin or simvastatin plus ezetimibe. Let me illustrate. In the IMPROVE-IT, the patients using simvastatin had an LDL of 70, while the patients using simvastatin plus ezetimibe had an LDL of 54. In other words, there was a 23% LDL reduction, right? And we know ezetimibe gives approximately a 23% LDL reduction. Now, 23% lower is an absolute number of 16 milligram per deciliter. If we now extrapolate this to 40, that means we don't have a 20% relative risk reduction, but we have roughly an 8% relative risk reduction, right? Baseline level in terms of absolute risk was 5%, so an 8% lower risk translates in 0.4% absolute risk reduction. So it went from 5 to 4.6. Now that is a lower risk, but a 0.4% absolute risk reduction is not something that will jump on the tables and say, wow, you know, we have conquered cardiovascular disease. No, it is a slight reduction which is beneficial, but we have to take into account what is the cost. How much do we need to pay to have this 0.4% absolute risk reduction? Had we used patients with higher LDL, so for instance, 152, and with a similar 23% LDL reduction, you would have lowered your LDL to 118. That means 35 milligram lower, again, in relationship to the 40 milligram here, 17% relative risk reduction. Absolute risk is higher because cholesterol is higher. So 17% from 7.8 is a 1.4% absolute risk reduction. Now, that is something that becomes more clinically relevant. And when we now look at the graph, you can appreciate that everywhere you get a 23% lower LDL when you're using ezetimibe, but the lower your baseline level, the lower the impact will be on your cardiovascular risk. Yes, there is no absolute difference in terms of uptake again, but the price you pay for this slight improvement can be high. Another interesting study that I wanted to share with you is this article that came out in December 2022. It is by Paul Durrington and Hendrian Soran, well-known clinical trialists and lipid experts from the UK. And what they wanted to know is, what is the sweet spot for LDL lowering? Yes, they know, going lower is better. But how much more better is going from a target of 100 to 70? Does that make really a clinically relevant difference? And if we go from 70 to 55, what do we get from that? And this is what they found. It's a little bit complicated slide, so let me show you. They wanted to know the 10 years number needed to treat. So the lower the number, the better, right? And then they looked at patients with different ASCVD risk, going from 5% to 50%, and looking at different pre-treatment LDL cholesterol levels.